possibly one of the most eloquent voices you'll ever hear in healthcare. Even if you don't agree with some of his statements, you might just feel compelled to accept them anyway. Our guest today is Dr. Kwame McKenzie. I've met Kwame a few times, and without hesitation will always set time aside for him. And if you are ever provided that same opportunity, I suggest you grab it. I am Matthew Hart, and welcome to Health Policy Off Script, where we review hard truths and difficult questions. How do we move forward with mental health and mental illness? A big question, but we'll do our best to break through the ice today. Leading today's podcast are the wonderful voices of Ivy Bourgeault and Dale McMurchy. Ivy, Dale, I'm looking forward to it. Take it away.
Thank you so much, Matt. And today's topic is of great interest to me, mental health care. Today we are thrilled to be joined by Kwame McKenzie to discuss this topic. Professor and Dr. Kwame McKenzie is CEO of Wellesley Institute, a full professor in the Department of Psychiatry at the University of Toronto, Director of Health Equity at the Centre for Addiction and Mental Health, otherwise known as CAMH, and a practicing psychiatrist. He has worked across a broad spectrum to improve mental health, population health, and health services for over 3 decades. Welcome, Kwame.
Thank you very much for having me here, Ivy. It's a pleasure to be here.
Well, let's start off just for our audience with a quick note about terminology, a bit of background. Today we're going to use the term substance use rather than addiction, and we will differentiate between mental health and mental illness. Kwame, can you elaborate on this and why these distinctions are important?
Okay, well, it seems technical, but it's really important. About 15% of people in the population have a diagnosable mental illness. So when we're talking about mental illness, we're talking about 15% of the population who, if they went to a clinician, would get a diagnosis in one of the diagnostic manuals, either the American or the European one, and they get a diagnosis of mental illness. Now, many more people have problems with their mental health or psychological problems that are not severe enough to be considered mental illnesses. You wouldn't get a diagnosis. They may be temporary, they may be less severe, but they'll impact their lives, but they're not actually mental illnesses. And we tend to use the phrase mental health problems or problems with their mental health when we're talking about people in that situation. Like everything in medicine, things change over time. Mm-hmm. So we used to talk about addictions, and then we used to talk about substance misuse. But these days, people talk about substance use. And it's actually really useful to consider it that way because it helps us understand the full impact of using substances. For instance, if you talk about people using alcohol, there's a relatively small percentage of people who use alcohol who people would say are addicted to alcohol or alcoholics. People used to use that phrase. But there are lots of people who drink too much. And there are lots of people who drink maybe think that they've just got normal social drinking, but that's having an effect on their health and on their family. And so if you just looked at people who were addicted, you'd miss the vast number of people who are using alcohol. It's impacting them socially, it's impacting their health, it's impacting their family, and it's impacting the economy. So if you start thinking about substance use and substance use health, you get to measure the real impact.
So let's move on to the challenges, of which there are many in the mental health and substance use health care delivery system. And we have an embarrassing situation where Canada ranks amongst the worst in comparison to other high-income countries for unmet needs for mental health and substance use health issues. So what's going on here?
Well, I think there are 3 things that are happening. The first is that people's lives are becoming more stressful. We're actually creating more mental health problems, whether it's through pandemics, global warming, war, social isolation, austerity, or affordability issues. We're creating more need for services. The second is at the same time, we're on a journey, an evolution, a social evolution where we're trying to become more sensitive. The next generation are more sensitive than the previous generation. They're more attuned to their mental health needs. But while we're on this journey where people are becoming more sensitive, actually increasing their resilience at the same time.
Mm-hmm.
So whether it's through the social determinants of health, or whether it's through the fact that we're creating sensitivities rather than necessarily resilience, we are producing more need for
Mm-hmm.
support. But at the same time, we're not creating more services.
Exactly.
Okay,
So
so
that's the juxtaposition.
juxtaposition is we're increasing need, and for various reasons, we're not increasing services to the same degree.
So let's talk a little bit about services, because there's challenges within the Canadian health system in terms of the inclusion of mental health and substance use health services, things like funding parity in terms of mental health. So could we talk a little bit about that?
If you look across high income countries, between 10 and 12% of health service spending tends to go on mental health. If you look in Canada, it's between 7 and 8%. So we're about a third down, where we're at 60% of what we should be.
Mm-hmm.
And that leads to problems. Mental health services tend not to be things where there are huge amounts of spending on, surgeries or ultrasounds or all sorts of technology. Most of the technology is people or medicines.
Is that public spending or private? Does that include private, your 7 to 8%?
I think that's total. I mean, I'd have to look it up. I'm pretty sure that's total spending. But remember, up until relatively recently, the amount of the public spending on mental health far outweighs the private spending on mental health. On substance use, private is considerable because public is low. But even when you look at private spending, so a lot of the private spending on mental health is through employee assistance programs, where you can get counseling or other supports that come as part of the package in your benefits package. But those are really limited. And so the actual spending on that is sort of fairly low, because the amount that maybe you get to spend for a whole year on your EAP, your employee assistance program, would be maybe 2% of what it would cost for one day in a hospital bed.
Wow.
Yeah.
And that's coverage for services for people who have benefits, and for people who don't have benefits, they don't have access to that. And it's very interesting to look at utilization of EAP services or employee and family assistant programs. They're actually quite low. So even when somebody has coverage, there tends to not be utilization of those services for a variety of different reasons. Maybe they don't need it, or maybe there's a stigma in utilizing those services. Maybe they worry about, their employer knowing that that they're using them, even though they don't. Why do we have that in Canada?
So I think that one of the things that is important, just to pick up on this before answering your question, is that the people who are at highest need for mental health care are the people who are least likely to have employers who have benefits programs.
Correct.
Just to go back to the balance between public and private, most of the public spend, and why the public spend is so high, is because most of the need is in groups who do not have any private coverage at all.
Okay.
And so out-of-pocket spending is going to be low. Plus, on top of that, the levels of employment in people with serious mental health problems, which are the most costly mental health problems, is so low that they haven't got money for out-of-pocket expenses. Now, back to your substantive question. There used to be a joke, I think you may have heard it. I think I told it to you before. Why did the Canadian public policy chicken cross the road?
Okay, why?
To get to the middle.
Okay.
Yeah. And the thing about that is that there's the American system with this huge out-of-pocket expense. There are European systems with very small out-of-pocket expense, and there's a Canadian which sits somewhere between, with a whole number of things that are covered by the Canada Health Act. And the Canada Health Act, when it was first written, was written to cover physician-linked services. And so these are quite specific. So if you have mental health where you have some things that are linked to a physician, a whole bunch of things that aren't, their social work, their psychology, their occupational therapy supporting you at home, there are all sorts of peer support. Those things are discretionary as to whether they're covered by your province or not, because they're not remunerated under the Canada Health Act. That puts psychiatry at a disadvantage with regards to the percentage of taxpayer money that would go into health.
But that seems to me that we've created a system where essentially everything is downloaded to a crisis, and then you get access through emergency and hospital care. There is publicly funded short-term help, and that's always been in short supply. So what happens if you need long-term support? Either you wait ages or you have to pay privately. And it just seems completely backwards to the way in which the system should be structured.
Yes, Dale, I would agree. I would think that if we were to think about building mental health services based on evidence and based on need, we would fund them better to start off with, because the burden of disease, of mental health issues, and is about the second greatest in all diseases, right? So it's one of the most important diseases with regards to, disability adjusted life years. So measures of the impact of a disease. So you'd fund it better to start off with. Next, you try and work out who needs the most support, and you think, hey, we would fund those people. And because we know that if we don't fund those services comprehensively, people are going to end up on the streets, people are going to end up in prison, people are going to end up dead. And then we would think about services for people who perhaps have common mental disorders or less. One of the things we would also think of doing is making sure that we have the right people, so supporting people in the right way. So if you've got a depression or something like that, you'd really want family doctors and nurses at the practice level and social workers to be doing most of the care there. But if you've got longer term serious depressions or longer term serious psychosis, you'd want that dealt with by a team that has more expertise just in mental illness. So I totally agree with you. There's an underfunding problem, there's a resource issue, and there's also getting the right resource to the right people, which is another issue we have to deal with. And when you get it wrong, you end up with one of the things that we have at the moment. So if you have a diagnosis of schizophrenia, on average, you're going to die 20 years younger. This is a huge problem of losing 2 decades of your life. But if you don't set up your services correctly, people don't get the right supports. People only get the supports in emergencies, as you were talking about, Dale. People don't get primary care support for their physical illness that goes with mental illness. People are in and out of hospital, and people don't get the social support, such as supportive housing if they need it, or supported work if they need it. then people end up not only with a chronic illness, but a chronic illness that is going to significantly decrease their life expectancy.
So how do you move beyond accountable to some kind of standards in terms of these are leading practices in the care of mental health and substance use health? How do we get to that point?
So I do think that provinces have to decide what they are going to pay for, what they're not going to pay for, and how they're going to pay. At one time, I lived in Belgium, and in Belgium, they similarly have independent hospitals and independent groups, independent family doctors, all working in the community. But the thing that pulls them all together is that the system is really clear what they pay for, what they don't pay for, and what you need to do to get payment. They build these protocols into the payment structure of the system. So you don't just get paid as a hospital, you get paid as a hospital for doing certain things in a certain way. And actually, the amount you get paid depends on you doing certain things in a certain way. People are specific in what drugs they'll pay for and what drugs they won't pay for. People are specific that are less specific around exactly what the care pathways or the care standards should be, even to the point where when I was involved in working on care standards in Ontario, these were not binding.
Okay.
So they would produce these standards, this is the way things should work, but they weren't binding. When they do make them binding, like say, for instance, in Ontario, when they started Cancer Care Ontario and they started saying, this is how cancer is going to be treated, it's going to be treated the same everywhere, outcomes just improved and improved and improved and improved. And I think if you can do some standardization work in mental health, it's useful. The thing you have to be a little bit careful of is that a lot of mental health services, when they do standardize, end up being one size fits all. And in diverse populations, one size fits all isn't usually the best way of going. You have to have enough diversity in your offerings to make sure you get equity of outcomes. And so and so if you decide you're going to fully standardize, you have to make sure that that standardization is going to work across different, very diverse population groups.
So we've talked about there not being enough supply of services and providers for mental health and substance use. And yet, federal and provincial governments have identified mental health and substance use as priorities. And in fact, the federal government earmarked money for mental health in two transfers of late, in 2017 and 2023, that went to the provinces for mental health. Ontario in 2019 said, oh, we have $4 billion over 10 years for mental health. But where's the money and where are the outcomes? What do we have to show for these billions of dollars that have been allocated to mental health?
I think there are a couple of things that are worth stating. We actually have all over Canada fabulous mental health clinicians doing fabulous work. We have some really great services. We are treating more people than we've ever treated, but we're at a time of population and need increasing significantly and costs increasing significantly. In Ontario, they were really clear that they were significantly increasing mental health spending. And there was a pile of money which came from the feds, and there was a pile of money which came from Ontario. This was true. It was marginally greater than an inflationary increase in the actual amounts of money that were needed in the system. So it was never going to make a big difference.
So it wasn't just how they're allocating those funds, like prioritizing perhaps more community over crisis, or was it just it wasn't enough?
All of that is true, but it was never going to be enough. To tell you the truth, the big challenge for mental health services is it's not completely clear that you can treat your way out of a social crisis. It is not clear that if you're looking at youth and 46% of them say they're anxious because of climate change, that a clinical response to that is ever really going to work. One of the issues that we have is defining who needs clinical services and who needs social policy interventions to make their lives less stressful. Recently in Toronto, we did a mental health report card, which showed that the number of people saying they had good mental health had decreased from 73% in 2015 to 52% by 2022. 7 years and a 21% decrease in the number of people with good mental health. You can't treat your way out of that. When we asked people what was going on, why is your mental health deteriorating? They said, well, we don't have enough time to live our lives. We have bad jobs and we have financial insecurity. Loneliness is a significant issue, and our communities are not as cohesive as they used to be. You can't treat your way out of those problems. Those problems are all problems that have social policy interventions. And so I think if we really want to see our return on investment for the money we're spending on mental health, we need to decrease the tap. We need to turn off the tap. We need to decrease the number of people who need the services so that the services are under less stress and that they can start building real and relevant solutions that will improve people's outcomes. But if we do one without the other, services will always be under strain, and the groups that advocate and can shout the loudest and know how to get the ear of politicians are the people who will get the services. And the groups that don't know how to do that are the ones that won't get the services. So I think we have to think about how we do what we know the evidence suggests, which is move upstream and decrease the need for services.
You mentioned going upstream. If we were actually to invest in early childhood development and parental supports, poverty reduction, and income stability at the population level, like taxation and minimum pricing, and then address the community supports, wouldn't we be getting the biggest bang for our buck, even though those are the four things that wouldn't come immediately to mind when we talk about prevention of mental health and substance problems?
So, Dale, I think you're answering your own question there. So, sure, I think that if we go upstream and we start looking at the biggest drivers of mental health problems and we start dealing with them, I think that we will probably get a much bigger bang for our buck than just trying to treat our way out of a social problem. And if we were going to focus on treating, the big question for me is what equitable mental health services look like. Because even if we were to increase the money, if the money goes to the wrong place, we won't get the best bang for our buck. So yeah, totally agree. We might have slight differences in how we see about what are the biggest issues, but certainly that whole idea of financial stability, sort of basic income floor, and all of the other things that you need in order to get people out of poverty, but actually further than out of poverty and into thriving, are the things that you'd really want to do if you wanted an evidence-based balance solution to our mental health crisis.
So these are partly some solutions you mentioned, moving upstream, basic income floor, but the pilot studies ended up being defunded. We seem to be going in the opposite direction to where the best return on investment would be. So how do we turn that around?
I wish I knew the answer to that. If we're going to keep on going, we are really going to keep on going. We are going to be advocating for upstream issues. It will become more and more obvious, whether it's another pandemic, whether it is global warming, whether it is just the clear realization that so many people need services that we have to think of community-based alternatives or going upstream. I believe that the realization that we really have to think about public policy as a way of decreasing the problems and decreasing how stressful people's lives are, I think that is something that will come. I know that one of the biggest weapons of bureaucracies are inertia, but I think that one of the biggest strengths of communities are to stick at things. And I think that we do need to stick at this.
We had an income stability program or a basic income program in Ontario. A new government was elected, that was thrown out. We know around the control of addictive substances at the population level, and now in Ontario, I can pick up a beer at the gas station. There's always a revolving door around using evidence, and then politics comes in and trumps policy. How do we get around that? Are we going to be on that hamster wheel forever?
Yeah, I think that one of the things, because I have lots of sympathy with the fact that looking at things at the moment, it feels like we're in a really bad place and things are unraveling. But I have how can I put it? I'm in my 60s, and actually things have been much worse than this. They have been better, they have been worse, they have been better, but we are in many ways in a better social position, ignoring some of the turmoil there's been over the last 2 year or so. We're in a much better social position now than we were, say, for instance, 20 years ago, in many ways. We have taken steps forward and we've taken steps back. In 2020 and 2021, the poverty level in Canada was lower than it had been for the previous sort of 2 decades or something like that, right? Because of the CERB. And then it's gone back. And so now we're thinking, hey, it's gone back and food security's gone up and all of those other things. But actually, the poverty rate now is less than it was in 2015, right? So we take steps forward, we take steps back. If we can don't panic when we take steps back, but keep driving forward, we have found that we have made progress in many ways.
Thank you, Kwame. So what would you do? Like, we give our guests a magic wand, and it's a magic policy wand in particular. So what would you do? What would you suggest? New policies that would be implemented, going back to existing policies, spreading, scaling, importances of targeted investments. What would you do with that magic wand?
Well, that is a difficult one.
Mm-hmm.
So I would start by thinking about the 3 issues that I think are the big issues. The first question is, how do we make people's lives less stressful? Mm-hmm. One of the biggest stresses is financial insecurity. And so I'd like to try and take financial insecurity out of the equation. I'd like us to think of some sort of basic income floor. I don't know how we do that, but I know that if we wanted to get everybody who is living with poverty, out of living with poverty in Canada at the moment, it would cost us maybe 5% of the federal budget. Mm-hmm. That's it. And if we split it between the feds and the provinces, it would be 2.5% each, right? Okay. So we can do that. Yeah. If we want to start thinking about making ourselves and our communities more resilient, we really have to think at the community level about what they call the 5 a day for mental health. So that's keep people connected, exercise, learn new things, be mindful, and volunteer. If you can do that, and if you can have public policy which promotes that, your communities will be more psychologically resilient. And with regards to mental health services, I would like the Canada Health Act to change, but I'd really like those health transfers to be tied to the equitable delivery of mental health services, not just in percentage based on burden of need, but also to diverse populations, um, for people to get the money. I think we've got to start saying that provinces have to create mental health services that make sense, and the feds have to say, in order to get your money, you have to do that. So if I had a magic wand and three things, and I had those three things that I thought were that I think are the big issues, that decreasing the rates of mental health need, making people more resilient, and making services work, that's probably where I'd start. But if you gave me more time and more wishes, I'd probably go past the three wishes with my magic wand and start
Well,
getting into the
it's
depth.
not a genie's lamp, so you can have more than three wishes. Everyone thinks it's a lamp, but yeah, go ahead.
There's the problem, you see. This is me. I sort of pulling all of these. This is, I think my defense is I am being a classic Canadian of bringing all of these different cultures together. And, I've got my wand, my Harry Potter wand on one side, I've got my genie's lamp on the other side,
Yeah,
squishing them together
yeah.
in some sort of a melting pot to make a one idea. But yeah, there are loads of things to do. And I think it's been the tenor of our conversation is that we actually have a whole bunch of answers. And the question is whether we have the political will at the municipal, the provincial, and the federal level to really move on mental health, not to talk about moving on mental health, not to do a little bit or just expand one sector, such as the youth sector, but to actually say, look, people say this is really important to them. And the action you take has to reflect the importance that people give to mental health. And the only reason you're not doing this is because in the back of your mind, you say one thing, but you think you can get away with not doing it because of the stigma. And I think we really got to call people to account.
Thank you so much, Kwame, for this excellent discussion. Really insightful.
And thank you very much for having me. It's been a pleasure.